Module 2A. In the next several slides, we will be discussing the following list of cognitive behavior therapy characteristics and defining themes, including CBT as scientific and evidence-based, present-focused, goal-oriented, learning theory-focused, transparent in communication, with a flexible and individualized format. CBT also uses a stepwise treatment progression. It's a relatively brief therapy, and the use of collaboration is extremely important. Now we will examine each characteristic of CBT in turn. The interventions presented to patients in cognitive behavior therapy are scientifically evaluated in randomized controlled studies. These published studies are widely available and help inform the CBT therapist about which interventions may be useful to work with each patient. Although there are many well-validated treatment protocols for particular presenting problems, CBT also aims at testing hypotheses with the individual by assessing if a given intervention is actually helpful for your particular patient. As such, it is emphasized that objective measures such as clinical inventories are used to evaluate the progress of your patient throughout the course of treatment. In CBT, we are identifying current thinking patterns, current behavioral issues, and current environmental triggers. We are not discounting a patient's past history, but we are looking at how the patient is currently interpreting events in the here and now. CBT is also goal-oriented. We are determining specific, definable, and realistically achievable targets for intervention. An example of a behaviorally defined target goal would be a 50% reduction in frequency of panic episodes. A vague, unspecified goal would make it difficult to decide on the best intervention and would not allow for measuring outcome or change in symptoms. Remember that goals for treatment are always collaboratively determined between the patient and the therapist. Our understanding about how problematic thinking and behavior patterns develop and how they are maintained is based on learning paradigms. I will discuss operant conditioning and classical conditioning in turn. Many behaviors and thinking patterns are shaped over time by reinforcement. We tend to do more of something when there is a positive reward for it. This is called positive reinforcement. Or when there is a decrease in something aversive, and this is called negative reinforcement. We see this occurring with the tendency to avoid situations that create anxiety, say avoiding heights when there is a height phobia. We can also learn by association. Feelings can be paired or associated with triggers that can subsequently elicit that response. We see this classical conditioning occurring with phobia development, say developing a fear of heights following an incident where you fell off a ladder. Often there is a tendency for generalization of learning, say if a fear of ladders becomes a fear of heights in general. The goal of CBT is to provide patients with new, accurate information and replace maladaptive or unhelpful behaviors with adaptive ones. The therapist serves as a teacher or coach and provides that material that the patients can read, forms to self-examine and monitor, and basic education about the patient's particular disorder. There is also an emphasis in cognitive behavior therapy to provide transparent information. By transparent communication, we mean open communication with the patient. That is, if I have an idea, I will share it with them. The goal is to have both therapist and patient actively engaged in the therapy, brainstorming together, with the goal of the patient ultimately becoming his or her own therapist. The following video clip illustrates transparency and communication as an individualized treatment plan and theory-driven model for obsessive-compulsive disorder is discussed with the patient. As you watch this video, notice how the treatment plan flows directly from the individualized case conceptualization. The patient in this clip is a 40-year-old married man with a several-year history of obsessive-compulsive disorder. Symptoms include intrusive, obsessive thoughts about health, his and his family's, and a need for certainty about health issues. Compulsions included excessive checking, for example, online medical sites, medical books, and reassurance seeking from people in his life. Hi, John.
Hi.
What we're here to do today is talk a little bit about what we discussed last week in terms of the worried thoughts that you're having, but also, the behaviors that you're engaging in that are problematic for you. So I was thinking that maybe we could take a look at a diagram that may help us understand a little bit more about what's been going on with you.
Okay.
Would that be okay?
Sure, that's
okay,
great.
Great. So one of the things we've talked a lot about is your unwanted thoughts, the thoughts that are intrusive and are distressing to you. Can you think of the major thought that you've been having that's been distressing?
Well, like my son's health.
Mm-hmm.
If he gets a cough, what does that cough mean, and is he going to die from it?
Okay, so that's been the major obsession that keeps popping up.
Yeah.
So could we say your son's health? Son's health? Okay, oops, should spell it right. And how much do you believe that your son's health is bad and it means that something bad's going to happen?
At the time when I'm in the middle of it, 100%.
Okay, so you believe it a lot, 100%.
Yeah.
For certain.
Yeah.
Okay, and when you think that something bad's going to happen to your son, and you believe that 100%, how do you end up feeling?
I feel really anxious.
Really anxious?
Very anxious.
Okay.
Yeah.
Uncomfortable?
Yeah.
Okay.
Out of control.
Okay. And so when you start to feel really, really anxious and it's so uncomfortable, what kind of compulsion are you engaging in, or any ritual or anything to try to reduce that anxiety?
Well, what I want to do is take him to the doctor right away.
Mm-hmm.
I want to just watch him, make sure he's okay, still breathing, everything's okay. And I want to go online and just check out WebMD and all the different places I can find out about his cough or whatever's going on and see what's...
So you're doing a lot of checking behavior, right?
Yeah.
You're checking your son, checking online, kind of reassurance seeking, would you say?
Yeah, yeah.
Okay. And then, and once you do all that checking behavior, what effect does that have, would you say, on how you're feeling?
I feel better. I feel relieved.
So less anxiety?
Less, yeah,
Okay.
yeah.
So, in essence, it works,
Yeah,
right?
yeah.
Works for you, reduces your anxiety.
Yeah.
Now, and when that happens, does that relief that you're feeling, less anxiety, does that stay for a long time?
It stays until the next time he has a health issue.
Oh, okay.
And
All right.
then it comes back again.
Okay. And since he's a little boy, he could cough different times, so
Yeah.
maybe that's happening frequently.
It happens quite a bit,
Okay.
yeah.
And each time that happens, the same pattern keeps going over and
Yeah.
over and over again. Okay. So it works temporarily, but it's not really working in the long run, right? Means that your anxiety is increasing in the long run every time you have one of those kinds of thoughts.
Yeah.
And then probably what's happening is it comes back to make you more vigilant of those kinds of concerns. What do you think?
Yeah, I
Like
think
you're
so.
kind of watching and waiting to see if anything's going to happen with his health.
Well,
or
yeah, I want to be a good parent.
You want to be a good parent, okay, which makes sense. On the other hand, your son's a reasonably healthy boy.
Yeah.
Okay. So one of the things that we want to understand is how would you break into this cycle? How would you maybe respond less in this pattern? What do you think would need to happen?
When my son had a cough or something, I wouldn't respond to it in the same way, I guess.
Okay, so you would need to actually maybe sit with the anxiety, sit with the worried thoughts without doing this stuff.
Yeah.
Okay. Does that make sense to you?
Yeah, I guess it's just kind of scary.
It is scary. And probably your anxiety would actually increase temporarily, but over time, the belief would start to change, because if you didn't respond like this, the thoughts might fade out because you're not responding, you're not really reinforcing that thought, you're making it less salient in your mind.
Maybe, yeah, once I didn't do it and then my son was okay, it would change.
Right, so that would be important. So that could be something we continue working on.
Okay.
Does that sound all right?
Sure.
Treatment plans and case formulations can change when we learn new or different information that does not fit with the original formulation. We are always aiming to use empirically supported theories and treatments to understand our patients and then tailor the treatment to suit that individual's particular needs. During our clinical interview, and when we review completed questionnaires and inventories, we are assessing a variety of variables that will help us create a clinical formulation about the patient and guide treatment. In developing a cognitive behavior therapy case formulation, we begin to gather clinical information, including current, present complaint, and then we determine what diagnosis best fits presenting problems. While talking with a patient, you can begin to notice their style of communication. Are they meandering? Are they focused? Are they problem solvers? Are they avoidant, abstract, or specific? And you can begin to notice themes that may represent how a patient's core beliefs are operating. For example, is this a person who always puts a negative twist on things or may externalize blame? Basically, core beliefs are long-standing assumptions about oneself, the world, others, and our future. A working formulation should include an understanding about how this person's belief system affects his or her own current difficulties. In developing a clinical formulation, we examine historical triggers and how events are perceived currently. What are current activating and maintaining triggers? We also look at strengths and assets and adaptive skills, which the patient can build on. And all of this information will help us create a working hypothesis, which will lead us in helping us figure out a treatment plan. I help patients understand how their core beliefs affect or color all aspects of their lives by offering them handouts such as this one, which describe a depressed person's schema-driven view of himself, the world, and his future, all obviously being perceived as being very bleak. It's a good idea to examine how your own patient's particular automatic thoughts and perceptions fit with this kind of cognitive triad. In this video, we will be seeing a first session with a 67-year-old woman who presents with a long-standing history of depression, going back to childhood, but is exacerbated after recently retiring. As you watch, please pay special attention to how I am forming hypotheses about core beliefs and schemas, and how I weave in my formulation, which helps to begin the process of collaboratively discussing the treatment plan. Lucy, we've been discussing how your perceptions, your thoughts, and your beliefs affect and influence how you feel and then how you behave. And you've been mentioning that you've been having some trouble getting started on tasks. You've been procrastinating quite a bit.
Well, it's true. I have all this junk that's piling up around the house, and I really want to go through it and sort it and get rid of stuff, and I just can't seem to get started.
And how long has this been going on for?
Several years.
Really?
Yeah.
Several years? Is there any way that you're thinking about getting these tasks accomplished that may be interfering in getting started?
Well, I feel like why should I even bother, because I know I'm just going to screw it up.
Okay. Is that a common theme for you, worrying that you're going to screw things up?
Yeah. Yeah. I just feel like I can never measure up. I'm always going to get things wrong.
Okay. And then what effect does that belief, you think, have on your motivation?
And I just don't want to even bother.
Okay. Can you see how that pattern operates?
Yeah.
Yeah. Okay. And then do you have an actual history of screwing up on doing tasks?
Well, I mean, when I was working, sometimes I'd get behind on things, but I'd always get the tasks done in the end.
Okay. So in the decades that you were working and since then, do you have any actual evidence that you have a tendency to screw up?
No, I guess not.
So that's kind of interesting, isn't it? That one of the things that you said before was that you have a belief that you might as well not get started doing anything with your task because you're going to screw it up.
Yeah, I did say that.
Yeah, you did. You did. So I wonder if it's worthwhile for us to try to examine some of these kinds of beliefs and really assess if you have any valid, accurate evidence to support them.
Yeah. Okay.
Okay.
In this video, we will be seeing another first session with a 60-year-old woman with long-standing depression and drug addiction now in remission. Please notice how I share my hypotheses with the patient and again weave in ideas for treatment. For example, how becoming more active could benefit this patient.
So Lucy, we've been looking at a lot of different variables that could be either increasing or decreasing your depression. What have you noticed about your pattern lately?
Well, when I'm depressed, I really try to avoid people. I really isolate myself.
Okay. And so when we think about depression, that really does make sense. You've been feeling depressed, you've been having less motivation, less desire to see people and interact. So that's a really common side effect of depression. But what tends to happen when you feel depressed and down and then you push yourself anyway?
Well, I usually feel better, actually, a little bit if I do that.
Do you? Okay. And do you have much experience with that?
I'm usually pretty good at avoiding, but last week a friend of mine called and I actually picked up the phone instead of letting the answering machine take it. And we talked for a while, and that was good.
Yeah.
Yeah.
How did that make you feel?
I felt better. It reminded me that there are people who actually like me. You know, it made me feel like, you know, I'm not really all alone in the world, that it's not really true that people are just going to reject me
Okay.
necessarily.
Okay. So I wonder if we're onto something here.
Yeah, maybe I need to reach out more.
In the second part of this session, with the same woman, I begin to introduce the relationship between distorted thoughts and beliefs and mood. Notice how all hypotheses are transparently shared with the patient.
So we've been talking a lot about how depressed you've been feeling. Do you have any sense of what kinds of thoughts might be behind that depression? What kinds of perceptions?
Well, I just feel like I'm a complete failure in life.
Yeah. And can you say more about that?
Well, for one thing, I can't work.
Right. You can't work. And so by not working, that means you're a complete failure?
Yeah.
Okay. And why is it that you're not working?
Because of the depression.
Okay. So if you have depression and that leads to not working, that indicates that you're a complete failure.
Yeah.
Okay. And when you say those kinds of things to yourself, does it have any effect on what's going on in your life?
It just makes me feel worse, I guess.
Makes you feel worse. Okay. And how certain are you that you are a complete and 100% failure?
100%.
You're 100% certain. Okay. And does that feel like something that could change, that belief? Or is it pretty ingrained?
Yeah, that's how I feel.
That's just how you feel. Okay. Would you mind doing a little exercise with me? Because I think this might be helpful. How about if we switch roles just for a few minutes? And I pretend that I'm you, and I'm going to share all the same things that you mentioned to me. And then I want to see how you react to me, as though you were my friend, what you would like to say to me. Okay? Can we try that?
Okay, I guess.
All right. So I've been struggling with depression my whole life, since childhood. And I've really struggled. I've seen a lot of therapists. I've been on tons of medication. I've even had electroconvulsive therapy. But I still struggle. I really, really get very depressed to the point where I don't want to get out of bed in the morning, and I've not been able to work for a very long time. The fact that I can't work is clearly an indication that I'm a complete failure. What would you want to say to me?
Well, I don't think I'd want to say you're a complete failure.
Would you be thinking it?
I'm not sure.
Okay, fair enough. Let me go on a little bit. So I want you to know also that everyone in my family struggles with some form of mental illness. And my parents have been depressed their whole lives. My brother struggles with substance abuse problems. And I've been struggling since childhood. I've really tried hard to do all the right things and go to the, get the help that I need. But I really still struggle a lot. So I'm obviously helpless and hopeless and a failure.
Well, I wouldn't say that you were a complete failure, because it just makes sense that you would have to that you'd have these feelings and you'd have to find a way to deal with them.
So you wouldn't be thinking I'm a complete failure?
No.
That's interesting. Notice how that you have so much more compassion for me and kindness and really accuracy when you're talking to me. But I guess the double standard is that then when it goes back to you, you're not looking at things that way.
Right. I guess not.
Okay.
I see what you mean.
Yeah. So I wonder if that makes sense for us to continue looking at some of the ingrained beliefs that you have, and then see if we can together challenge them and look at them and see if they're completely accurate, or if there's maybe possibly another way to look at it. What do you think?
Okay. Yeah.
Makes sense?
Yeah.
Okay.
Remember to be flexible in creating a clinical formulation. Formulations can and should change if new information is collected that does not fit with the original formulation. This is a common error that beginning clinicians make. Do not dismiss contradictory new information. See if you can reformulate your conceptualization in a way that explains all bits of information that you gather. Also remember to regularly share your formulation with your patient. This is a way to foster collaboration and promote working together. The more explicit you are about the rationale for a particular intervention or line of discussion, the more engaged the patient will be in the therapy process. Goals are collaboratively identified and prioritized by patient and therapist together. The list of goals for treatment should be operationalized and measurable. For example, a 50% reduction in frequency of panic attacks as measured by the panic attack record. Specifically outline each treatment modality, for example, weekly cognitive behavior therapy.
ask yourself what interventions follow from the conceptualization and empirically validated theories. Also, are there any potential obstacles to treatment? For example, secondary gain from an ill role,